Hey everyone, today we'll be discussing the thyroid gland and the parathyroid gland. So the way the thyroid works, it's under the direction of the thyroid releasing hormone from the hypothalamus. That is then, TSH is secreted from the anterior pituitary, which goes over to the thyroid gland. And then two hormones are produced from the thyroid gland itself. First is thyroxine, also called T4 because it contains 4 iodine molecules. And the second hormone is called triiodothyronine, also called T3. And so those are what you get directly from the thyroid gland, the T3 and the T4. So you have several mechanisms here. You have, again, the hypothalamus, which stimulates thyroid releasing hormone. That goes off to the anterior pituitary, which that releases thyroid stimulating hormone. That carries over to the thyroid gland, and T3 and T4 are released. So here we look in this disease process, hyperthyroidism. And this is the excessive secretion of thyroid hormones. These hormones come specifically from the thyroid. So diagnostic findings for hyperthyroidism is you're going to see that TSH, which comes from the anterior pituitary, that's going to be low. And your free 3, T4, are going to be elevated. So you'll see those high, and then you're going to do an iodine uptake. Patients, when they need to find out more whether this is a thyroiditis or Graves' disease, they will do an iodine uptake. And this is kind of like a radioactive iodine, and then 6 hours later they see how it was metabolized. If it was metabolized way too fast, it was increased metabolization, then the person is positive for Graves' disease. If not, then it just may be a thyroiditis. An enlarged thyroid can also be felt by palpitating the gland and having the patient swallow. So here I have enlisted a video for you to watch from YouTube. You can take a look at that. So you kind of take the patient from behind and you ask them to take a sip of water and swallow, and then that palpitation or that thyroid gland can be felt. Now here's the thing, if a patient is very ill from their hyperthyroidism and they have an enlarged gland that is very obvious that you can see, just obviously if you can see, it's not advised that you stimulate that gland because you could cause a thyroid storm, and we'll get into that later. But if it's something that's obvious and you can see, there's no necessarily reason for you to palpate. But smaller, enlarged in the beginning process of the disease, yes, palpate. And again, that is by taking a sip of water. Primary hyperthyroidism and the TSH hormones are lower than normal. So many are names for hyperthyroidism. It's also called Graves' disease and Basedow's disease. You also get a thyroid toxicosis and exophthalmic goiter. So those are some names that are listed in your book. So assessment finding for a patient with hyperthyroidism or Graves' disease is these can be very mild or they can be very severe. So a patient will find hair. They would also have exophthalmosis, which is the protruding of the eyes. Patient can be very nervous, restless, have some emotional instability, insomnia, not able to sleep. You have to remember, during this process, everything is on high metabolism. The body is constantly going. So they may have a goiter. Patient is sweating. They are intolerant to heat. These are people you'll see out in the middle of the winter without a jacket, or 68 degrees in a room is just way too hot. They're just tearing their clothes off. They're sweating like crazy. Muscle wasting. You'll see that. These patients have tachycardia, palpitations, and can have high output failure. So because the heart in hyperthyroidism becomes tachycardic, it's working more than it should. And if our body is working, or that muscle is working more than it should, it can develop more muscle, which we don't need in the heart. So then you can get this high output failure or cardiomegaly in these patients. Patient will have an increased appetite, and they'll be eating everything under the sun, but they don't seem to be gaining weight. They're actually losing weight. They could have a fine tremor, and they'll have this pretibial myxedema. It's a little bit of a swelling on their lower legs. They'll have loose stools. So again, their metabolism is on overdrive. You can see in this picture this patient's goiter. That is very obvious. And again, you have to be very cautious in palpitating somebody that has Graves' disease, because you could cause them to go into a thyroid toxic crisis. So let's take a look at medical management for the patient with hyperthyroidism. One, we could use anti-thyroid drugs such as PTU or Tapazole. We could also use potassium iodide, which is also known as Lugol's solution, in conjunction with PTU for a patient that's going preoperative surgery for thyroid to kind of slow bleeding is one of the reasons. Or maybe that they're just not a candidate for other procedures. Another management is the radioactive iodine. And now this actually burns the thyroid gland. It actually radiates or irradiates the thyroid hyperplasia that's going on. So as a result of this, the patient will become hypothyroid. What's important to know about radioactive iodine is that patients will have precautions that they will follow as soon as they've had this. Typically for 24 to 48 hours, patients need to double or triple flush the toilet, typically using plastic dinnerware to eat, plastic cups, anything that can be thrown away. You don't want to contaminate or expose family members to this radioactive iodine that is being throughout your body. Clothes should be washed separately from other people's clothes if you're doing those. Another medical management is a subtotal thyroidectomy, or maybe they may possibly use a partial thyroid lobectomy or a total thyroidectomy. Hence, in any one of these, I must inform you that any removal or alteration of blood supply to the parathyroid, which is located in the thyroid gland, will result in hypocalcemia. So if you lose any of those glands from the parathyroid, or a lack of blood to those parathyroid hormones, will result in a patient with hypocalcemia. And any of these medical managements will result in your patient becoming hypothyroid. So they will have to take synthetic medication for the rest of their lives to replace the thyroid that they will be missing. Anti-thyroid drugs are used in blocking the production of thyroid hormone preoperatively or for long-term treatment. Again, the anti-thyroid drugs, the PTU or the Tapazole, have to be taken religiously. There is a high remission rate, and side effects of the drugs, you need to let your doctor know if you're having a fever, you become sick. Sometimes the drugs need to be stopped because they can increase white cell count. So it is a pretty strong regimen, and some people can't adhere to it, so they seek other alternatives. Now let's take a look at thyrotoxic crisis, also known as a thyroid storm or thyrotoxicosis. This is a life-threatening form of hypothyroidism. These patients need to be monitored frequently. These patients can develop very high temperatures. You find their metabolic rate is so increased. They have excess corticosteroids that are being used. Again, like I said, high temp, it wouldn't be unusual to see a patient with 105, 106 degree temperature. These patients suffer from tachycardia, and they can suffer from dysrhythmias such as AFib, supraventricular tachycardia. Again, these patients in thyrotoxic crisis have a markedly elevated T3 and T4. There is some speculation that triggers for thyroid toxic crisis is infection, DKA or diabetic ketoacidosis, trauma, toxemia, or pregnancy. So immediate management of thyroid toxicosis needs to take place. Antithyroid drugs such as PTU or methimazole are used to block the synthesis of thyroid hormones. Also, we can use IV corticosteroid, which could be given to replace depletion that results from the overstimulation of the adrenals during this hypermetabolic state. IV sodium iodide prevents the thyroid gland from releasing additional thyroid hormones. We don't want any more out there. It's already got enough. And then I listed this picture here for you because we use beta blockers, and more specifically your book says propranolol or Ingerol. And this reduces the effect of the thyroid hormones on the cardiovascular system. So we take the medication or the beta blocker. It blocks those receptors from inducing too much of a heart rate. It also, the heart rate stays normal, or actually brings the heart rate down, but it reduces some of those stress and anxiety factors for the patient. It kind of helps them out, kind of like that fight or flight that goes on with them. So these patients really need supportive therapy. They need antipyretic medications, and they need to get their temperature lower, but you don't want to do that too fast. So reduce the temperature, but again, like I said, not fast. Again, these patients are very important to manage right away. So hypothyroidism is going to be the complete opposite of hyperthyroidism. So instead of as we discussed, in hyperthyroidism, everything's on an increased metabolic state. Everything's just strung out, high as a kite. In hypothyroidism, this is going to be the opposite. Everything's going to be in a low metabolic state. Everything's going to be slower. You're going to find metabolism much slower. Patients will be gaining weight. They'll be bradycardic, but we'll go over a little bit more of that. But this will have minimal thyroid hormone secretion. So again, we have that thyroid releasing hormone from the hypothalamus, then to the anterior pituitary, and that releases the TSH. So at this point, it's going to be releasing a lot of TSH, and there's going to be minimal T3 and T4 releasing, because that's what's stimulating that metabolism. Okay, so we'll have a higher TSH, but they'll have a low T3, T4. And again, that's the diagnostic finding: high TSH, low T3, T4, and their radioactive iodine uptake is all going to be decreased. So after so many hours, they check the metabolism, and it's going to be low. So These patients will struggle with intolerance to cold. Again, this is complete opposite of the hyperthyroidism. They'll have a receding hairline. They'll have some facial and eyelid edema. They'll have a dull, blank, expressionless face. They're going to suffer from extreme fatigue. They'll have anorexia. They'll have brittle nails and hair. And they'll have some menstrual disturbances in females. They're going to have some muscle aches and weakness. And now, instead of having loose stools and diarrhea, they're going to be having constipation. They'll be lethargic, and they'll struggle with hair loss, and they'll have some apathy. Reasons for hypothyroidism: some of it's unknown etiology. Again, the other part is if they had Graves' disease and they did some radioactive iodine on that thyroid. Well, now they need that synthroid to help replace the thyroid hormone that they will no longer have anymore. So again, synthroid, unithroid, levothyroxine, levothyroid, those are all the medications that are used to treat hypothyroidism. And medical management of this, as far as the drug, they'll start you pretty much on a low dose. Typically it's about 0.88 micrograms, and then they'll recheck you in another month, and then see if you need a dose adjustment. You go up, and you can go up to like point or to 100 micrograms, or just slowly kind of increasing, lowering that medication dose. And you typically are seeing anywhere from 1 month and then kind of a dose adjustment for each dose adjustment, and then every maybe 3 months, and then maybe twice a year to once a year, till you fully get established, and your meds are working, and you're getting a good TSH level and T3, T4. Some late clinical manifestations of hypothyroidism is subnormal temp, bradycardia. They get some weight gain, and they'll have a decrease in loss of consciousness, thin skin, and cardiac complications. The major part of this hyperthyroidism is when it gets really bad, they go into myxedemia. And again, that can be a medical emergency. So that is hypothyroidism for you. So let's take a look at hyperparathyroidism. Hyperparathyroidism can be either primary or secondary. In primary hyperthyroidism is caused by an adenoma, a benign tumor, and it's located near or on one of the parathyroid glands. In secondary hyperparathyroidism, the parathyroid glands secrete excessive parathyroid in response to hypocalcemia. Maybe they have a low serum calcium level, and this results from vitamin D deficiency, chronic renal failure. Maybe the patient's taking large doses of thiazide diuretics, or excessive use of laxatives and calcium supplements. Again, you'll have excessive parathyroid hormone resulting in a rise of blood calcium levels. So your calcium levels are going to be high in hyperparathyroidism. Bones are soft and become weak because the bones have lost that calcium. Remember, if it's pulling calcium out of the bones, those bones are going to be very weak. They're very fragile. They're very tender, and they have pain on bearing weight. They're also predisposed to pathological fractures, so you got to be very careful with these patients in any type of contact sports, or you just got to educate on how they have to be careful with themselves. Patients can develop kidney stones because all that calcium is, all that excess calcium is going into the kidney, causing kidney stones. Can cause UTIs, or uremia may develop. Again, the diagnosis for hyperparathyroidism is they're going to have high parathyroid hormones. Also, x-rays will reveal that maybe their bones aren't as dense as they should be. Diuretics may be given to prevent renal disorders, which develop as a result of high blood calcium levels, like I said earlier. One of the nursing managements for this is you want to make sure that these patients do not develop any urinary calculi from the hypocalcemia. So you're going to look for flank pain, maybe they have a decrease in urine output. So one of the things that you're going to promote is hydration. You definitely want to make sure these patients are adequately hydrated so they can filter out all that stuff. The only treatment for primary hyperparathyroidism is the surgical removal of the hypertrophied glandular tissue, or the removal of the tumor in one of the parathyroid glands. And secondary hyperparathyroidism is basically correcting the cause. Is it a vitamin D therapy? Do they need more vitamin D in their diet? Do we need to correct the renal failure that they're having, or do they need calcium restrictions in their diet? Again, phosphates may be given to reduce serum calcium levels. Patient might have a thyroid lobectomy, and again, if we're pulling out those parathyroid glands and the thyroid, we are going to be hypocalcemic at that point, and we're going to be hypothyroid. So we'll need replacement medications for those hormones. So we want to encourage the patient to exercise to help those bones from releasing calcium. So the more exercise they get, they're not going to release those calciums. I need that calcium from my bones. We're also going to limit the patient's calcium intake, and we're going to avoid activities that could result in the injury so bones don't fracture. Again, these patients are very at risk for developing fractures. We read about how they have pain on weight bearing. They're very tender. Again, it's important to remember these patients can have pathological fractures with just limited movement because their bones have become so weak. So there is time that's going to need for them to be recalcified to become stronger. So that takes some time. So now let's take a look at hypoparathyroidism. This is a deficiency of the parathyroid, and this results from trauma of the glands, or maybe after the removal of the thyroid, or obviously the removal of the parathyroid gland. Patient becomes hypocalcemic. When it does become hypocalcemic, this actually affects the neuromuscular functions of the body. It causes like hyperexcitability, resulting in spastic muscle contractions. It causes paresthesias, some kind of abnormal sensations, maybe like numbing, tingling of the fingers or extremities. Assessment findings, very important because of these muscle excitability. One of the ways that you can find is tetany. And again, these are the muscle twitches that you will see. They report like a numbness or a tingling in the fingers or toes. And these are involuntary movements. Also, some muscle cramping may be present. And they have that tonic reaction where it's more of a contraction or flexion of the fingers, arms, toes, anything like that. One of the ways to identify it is through Chevaux's sign. And through Chevaux's sign, if you, as a nurse, if you tap the patient's facial nerve, which lies in front of the ear, the patient's mouth or lower facial features twitches, a jaw actually tightens. That would be a positive Chevaux's sign, and that would be a sign of hypoparathyroidism. The other test is a Trousseau's test, and this is done by placing a blood pressure cuff on the upper arm. You inflate the blood pressure cuff anywhere between the systolic and the diastolic pressure, and you leave it on for 3 minutes. And the nurse observes for the patient actually starting to have a spasm of a hand. It's called carpopedal spasm, and which is, you'll identify it by the hand actually flexing inward. So that would be a positive Trousseau sign. Patients with hypoparathyroidism can get laryngeal spasms, convulsions. They could actually go into respiratory paralysis, and this can go into death. So it's very important that these patients get the replacement that they need. Okay, again, in hypoparathyroidism, we're going to check our serum calcium, and those calcium levels are going to be low. And then we're going to check the phosphorus, and those phosphorus levels will be high. Now, there is an inverse relationship between calcium and phosphorus, if you haven't identified that yet. So if calcium is low, phosphorus tends to be high. And if the calcium is high, the phosphorus tends to be low. So also diagnostically, we're going to check radiographs. We want to see if the patient has too much density in their bone structure. Medical management, we're going to give them IV calcium salts. And you want to have these, because of those laryngeal spasms, you want to have endotracheal or respiratory stuff available in the event the patient needs an endotracheal intubation or mechanical ventilation immediately at the bedside. Patients are going to start taking oral calcium. Again, we're going to monitor signs for tetany. We talked about Chevaux sign and Trousseau sign. And we want to keep emergency trach equipment at the bedside. Again, if that patient goes into a laryngeal spasm and they cannot breathe, we need to do an emergency trach at the bedside. These patients would typically be in an ICU, and that's where you would do an emergency trach. There's not enough time to get a patient down to the OR to do an emergency trach. So that is important to know. That spasm can happen quick. We're going to definitely monitor for cardiac dysrhythmias. When your patient is hypocalcemic, you're going to see some problems on your monitor, and you might see an elevated QT in their electrocardiogram. But again, that's a little bit more advanced for you, but you will see cardiac dysrhythmia.